So my job over the next 20 minutes is to place before you my view that it is the liver that is the root cause of type 2 diabetes, and then hopefully provide you with some learning points as we go along. Well, how is normal metabolic homeostasis maintained in the fed and the fasting state? So, with intake of carbohydrates in the fed state, there is increase in the plasma glucose, stimulation of insulin from the pancreas, and the insulin has several mechanisms by which it can store excess calories, some of which are shown over here. At the level of the skeletal muscle, the insulin promotes the transport of glucose and glycogen synthesis. At the level of the liver, it suppresses gluconeogenesis and at the same time increases both the synthesis of glycogen and lipogenesis. And at the level of the adipose tissue, the insulin would suppress the lipolysis and promote lipogenesis. In the fasting state, when the insulin levels go down, there is a reversal of these processes. There is increase in glycogenolysis and gluconeogenesis, and lipogenesis decreases, as well as there is increase in the lipolysis in the adipose tissue. This is what happens in normal individuals. So the first learning point is, what's the relative contribution of glycogenolysis and gluconeogenesis? So if you have a short-term fast of up to several hours, it's the glycogenolysis which is going to cause the hepatic glucose production. And within 1 to 2 hours after eating, this process is going to be suppressed by insulin. If you fast for longer hours, more than 12 to 14 hours, then the glycogen stores would get depleted, and therefore there will be an increased contribution of gluconeogenesis to the total glucose supply. What happens in type 2 diabetes? In type 2 diabetes, in the fed state, okay, remember there is a lot of ectopic lipid accumulation in various tissues that you can see as yellow blobs. So at the level of the skeletal muscle, because of the increased intramyocellular lipid accumulation, there is a decrease in the transport of glucose across the skeletal muscle. There is decrease in the glycogen synthesis, and this excess glucose is going to be diverted to the liver. But at the level of the liver also, there is excess ectopic lipid accumulation, and therefore, there is an inability of the insulin to modulate the process of gluconeogenesis and activate the glycogen synthesis. So the result is that there is increase in the gluconeogenesis, decrease in the glycogen synthesis. Now these red crosses actually are denoting the defective insulin signaling at the level of the tissue. Now if you observe here, there is no red cross at the level of lipogenesis. So while there is increased gluconeogenesis, there is no resistance as far as lipogenesis in the liver is concerned, and therefore, even in type 2 diabetes, the increased lipogenesis continues in the liver. And this, coupled with the increased glucose that is coming from dietary sources as well as diversion from the muscle, will lead to further increase in lipogenesis and worsening of the so-called non-alcoholic fatty liver disease. At the level of the adipose tissue, again, there is a resistance over here, which promotes, therefore, increased lipolysis, which you can see also in the fasting state. So there is increased lipolysis, increased free fatty acids, and these free fatty acids again go to the liver, where they are re-esterified in the liver and in various other tissues. So the learning point is, if at all there was an argument to be made, what comes first? Whether it's the liver or the pancreas, in fact, I would say it's the muscle resistance that comes first. So the muscle and adipose insulin resistance, they antedate the hyperglycemia by several years, but they would remain relatively stable throughout the course of the disease. The rise in the hepatic glucose production occurs relatively late in the natural history of the diabetes, occurs before the pancreatic defect, but after the muscular or the adipose cell defect. But this defect at the level of the liver, unlike that in the muscle and adipose tissue, worsens progressively and finally becomes refractory to treatment. Now, I'm showing the response of the liver. Of course, you have liver over here, fat, and the muscle, and this is how the pancreas responds to a glucose load, okay? I'm not going to discuss the fat and the muscle over here. What I've shown is the normal response of the liver to a glucose load. So So what happens, these are the transcription factors which play a role in gluconeogenesis and triglyceride synthesis. We need not bother about them at the moment, but in normal individuals, there is a suppression of hepatic neoglucogenesis, but there is increased hepatic lipogenesis, with the result that there will be decreased glucose coming out of the liver, but increase in the triglycerides. Okay, this is in normal individuals. Now, these are mice, of course. These are normal mice, and these are mice with type 2 diabetes. Now, in type 2 diabetes, the level of the insulin resistance at the level of the liver is selective. So there is a resistance to the action on the gluconeogenesis. So there is no suppression of gluconeogenesis. So the glucose is increased, the output from the liver, but there is no resistance. It's a selective resistance. So there is no resistance at the action of lipogenesis, with the result is that if you have a selective insulin resistance, as happens in type 2 diabetes, there is a double whammy. There is a combination both of increased glucose and increased triglycerides. If now, however, you take mice which are liver-specific insulin receptor knockout mice, they don't have selective resistance, they have pure insulin resistance. So you will have resistance both for neoglucogenesis as well as lipogenesis. The result is that they will have hyperglycemia, but they will not have hypertriglyceridemia. And therefore, this is a milder condition. So this is one condition where the paradox is that selective insulin resistance is worse than total insulin resistance. And this selective insulin resistance occurs in type 2 diabetes. So learning point, the pathogenic paradox of selective hepatic insulin resistance leads to defective control of hepatic glucose production by insulin, while maintaining the lipid-promoting effects of insulin, which leads to a combination of hyperglycemia and hypertriglyceridemia. Now, the control of hepatic glucose production can be direct, that is direct action of insulin at the level of the liver, and this is independent of the action of glucagon and other factors such as, say, free fatty acids. So you have something called as a direct action of liver, and this overrides the effect of glucagon. But you also have various indirect controls of hepatic glucose production, such as delivery of free fatty acids, glycerols, amino acids, and adipocytokines like adiponectin and resistin, etc., which go to the liver. You also have a neural control, which is vagal specific, but also non-vagal, and it has been shown that selective hepatic vagotomy suppresses hepatic glucose production. You also have the ratio of glucagon and insulin, which influences the hepatic glucose production. And you finally also have intrahepatic fat storage in the form of complex phospholipids accumulating in the liver, which influences hepatic glucose production. You also have accumulation of resident macrophages in the liver, which can influence hepatic glucose production. So you have a direct control, you have an indirect control, which is important. In normal individuals, remember, it's the direct control that is important. But what happens when you're not normal? So if, for example, when the direct pathway is defective, as occurs in obesity-associated diabetes, it's the indirect control of the regulation of hepatic glucose production which becomes the major determinant. The other learning point is this enigma of the diabetic liver can be explained by a new paradigm, wherein hyperinsulinemia will directly drive, because it's a selective insulin resistance, it drives the hepatic lipogenesis and lipid accumulation, but the indirect mechanisms, for example, excess circulating free fatty acids, will block the ability of the insulin to suppress the hepatic glucose production. Now, this relation of non-alcoholic fatty liver disease and metabolic syndrome is bidirectional, and the common unifying feature is insulin resistance. And if there is one factor which single-handedly, maximally influences hepatic glucose resistance, it's the level of diacylglycerol, which is the penultimate product that you get when free fatty acids are converted to triglycerides. Just before triglycerides are produced, you have a product called diacylglycerol. So the level of diacylglycerol in the liver will finally influence the insulin resistance at the level of the liver. What happens is it activates protein kinase C epsilon, decreases the insulin signaling at the level of the insulin receptor, leading to hepatocyte insulin resistance. Various inflammatory cytokines promote the conversion of so-called harmless steatosis to non-alcoholic steatohepatitis, okay? And there is also increased expression of PAI1, and when you have increased PAI1, it decreases the proteolytic mechanisms, decreases the collagen degradation, and leads to increased fibrosis. Now, there is also something called fetuin B. It's a hepatocytokine which is expressed in the presence of hepatic steatosis, and this hepatocytokine promotes hepatocyte insulin resistance. So when you tackle fetuin B, the hepatic glucose, the hepatic resistance to insulin decreases. So this is how NAFLD and metabolic syndrome are interrelated. So the learning point here is, it's not so much your BMI, it's not so much your visceral adiposity, but what finally matters is your intrahepatic triglyceride content. And if I have to be more specific, it's the intrahepatic diacylglycerol level, which is a better predictor of hepatic insulin resistance. And therefore, if you intervene and decrease the intrahepatic triglyceride content, that is associated with reversal of hepatic insulin resistance. I draw your attention to a nice review article published a couple of years back in the World Journal of Gastroenterology, and they've described a new entity. It has been described before. It is hepatogenous diabetes. Okay, this is not recognized by the ADA as such as a new entity, but they propose that we should now recognize that there is an entity called hepatogenous diabetes. And where do we see it? It can be identified in as many as 80 to 85% of patients with chronic liver disease who have no previous history of diabetes, and they have absence of standard risk factors for type 2 diabetes like high BMI, family history, and hyperlipidemia. It's more likely to occur in liver disease, which is due to hepatitis C virus. Now, what's so special about hepatitis C virus? It's thought to damage the pancreatic cells because it induces autoimmune destruction. It directly affects the pancreatic beta cells. It also causes resistance to the action of insulin. You can also get it in alcoholic and cryptogenic liver disease. Now, the worsening of hepatogenous diabetes, it runs in parallel to the severity of liver disease. So if you have a more severe liver disease, you're going to have more severe hepatogenous diabetes. And for example, after liver transplant, there is a reversal or an amelioration of the hepatogenous diabetes. In fact, it's a marker of poor prognosis, just like the presence of hepatic encephalopathy is a marker of poor prognosis. Similarly, the presence of hepatogenous diabetes in a setting of chronic liver disease is associated with increased rate of liver complications like hepatic encephalopathy itself, esophageal variceal hemorrhage, spontaneous primary peritonitis, renal impairment, and in fact, there is a lesser response to interferon-based treatments if you have hepatogenous diabetes. In fact, the overall mortality is poor in people who develop hepatogenous diabetes. So if you can reverse that, then it improves the survival. So the learning point is, if you have a patient with chronic liver disease, please search for diabetes, and it's helpful if you can classify it as hepatogenous or type 2. You monitor the liver and cardiovascular complications in these individuals, you start treatment timely, and you take into account the liver function, use liver-friendly drugs. In patients who are infected with hepatitis C virus, you preferably administer insulin sensitizers in order to increase the virological response to antiviral therapy. Before transplant, you again search for diabetes to administer a treatment that can improve the post-transplant outcomes. And those with decompensated liver function, you start therapy with anti-diabetic drugs or insulin, preferably in in-hospital patients. My final, or the last but final point. I said the liver defect comes before the pancreas defect. I'll explain how. And this is called as the twin cycle hypothesis. So if you have a positive calorie balance, increase intake of calories on a sustained basis, that's going to lead to increase in the liver fat. And this process of increased accumulation of liver fat following increased caloric intake is worsened if there is pre-existing insulin resistance. Now, once you get increased liver fat, there is resistance to the suppressive action of insulin on the hepatic glucose production, and therefore, there is increased hepatic glucose production. If there is increased hepatic glucose production, the basal insulin secretion increases, and this sets off a vicious cycle. At the same time, the increased liver fat is going to increase VLDL in the blood, and this VLDL, or more specifically in particular, triacylglycerol, is increased, and various tissues are exposed to high levels of triacylglycerol, and the pancreatic islet is particularly prone to the toxic actions of triacylglycerol. So with the result, when there is exposure of the islet to this hyperglycemia, as well as increased triacylglycerol, the insulin response to food decreases, and that perpetuates the hyperglycemia. So another vicious cycle is set off at the level of the pancreas. So the vicious cycle at the level of the liver comes first, followed by the vicious cycle at the level of the pancreas. And if the pancreatic islet cells, it is thought that if they are exposed to mild hyperglycemia and increased triacylglycerol over a period of 2 years, that can permanently damage the islets and can lead to sustained or definitive type 2 diabetes. So the learning point, the fatty liver becomes established years before the onset of type 2 diabetes. It's necessary but not sufficient for its development. And the subsequent periods of years of overexposure of the islets to elevated plasma diacyl and triacylglycerol level and a modest increase in plasma glucose is necessary to precipitate beta cell decompensation. So if you ask me, muscle resistance comes first, adipose level resistance comes first, then the hepatic resistance, and then the pancreas. Okay, that's how it is. Now, it's no surprise, therefore, that the drug which is drug of first choice in type 2 diabetes predominantly targets the liver. That's metformin. There are various putative actions of metformin, but an important action is to decrease hepatic neoglucogenesis. There are, of course, other molecular mechanisms as well. And so it is not surprising that there are several agents which are being studied which target the liver. They could be activators of glucokinase. The problem with them is that they don't show a sustained action. And they also show dyslipidemia and hypoglycemia. Then you have inhibitors of fructose 1,6 biphosphatase, inhibitors or regulators of insulin signaling pathway, inhibitors of glycogen phosphorylase, and glucagon receptor antagonists. Again, problem with glucagon receptor antagonists is vomiting, sometimes the non-specificity. But they are being studied, and I'm sure if we can take care of the adverse effects, it will give a substantial addition to our therapeutic armamentarium. So the last learning point is, although there are concerns about potency, tissue selectivity, and undesirable metabolic effects like lactic acidosis for all these liver-targeting drugs, further investigation into specific methods for pharmacologically targeting pathways in the liver will likely be fruitful in the search for new type 2 diabetes drugs. I think I'll conclude my talk. I hope I have persuaded you that it's the liver that's the root cause. Thank you so much for your patient listening, but remember, it was the liver that is the root cause. Thank you.